Good morning, everyone. I am very happy to be here today to present you my progress on my PhD topic, IgA Vasculitis with nephritis, challenges and updates in the management of pediatric patients. I am Mădălina Andreea Beldie. I'm a first-year PhD student and a second-year pediatric nephrology resident doctor, and this is where my vision started from. By seeing everyday children fighting chronic kidney disease, I realized how important it is to address all the pathologies that can lead to it. This is why my vision is to decrease the chronic kidney disease burden in IgA vasculitis pediatric patients by improving their management. Here you can see the first three projects that I started during the first semester of this year, and I want to talk about the first one more in detail for the beginning. The first project is entitled Investigating the Predictive Accuracy of Serum and Urinary Biomarkers for Renal Involvement in IgA Vasculitis Pediatric Patients, and we will use the methodology of systematic review and meta-analysis to do it. IgA vasculitis is a multisystemic disease, and it affects between 3 to 27 cases per 100,000 children. The involvement is multisystemic, but the renal one is the most severe because also a late diagnosis means an irreversible evolution to chronic kidney disease, and in up to 7% of the cases to end-stage kidney disease. The problem here is that there is a lack of evidence-based guidelines for diagnosis and treatment for these patients. And what can help us in this pathology is having a better risk stratification, which means an earlier diagnosis, a better choice of treatment, and a more accurate indication for biopsy. And this can be attained possibly by biomarkers. This is why our aim is to identify predictive serum or urinary biomarkers for renal involvement in order to limit renal complications. We started from the question which biomarkers have the highest predictive value for the onset of renal damage in patients with IgA vasculitis and used the PFO framework to answer to this question. We hypothesized that the neutrophil to lymphocyte ratio, urinary KIM1, and NGAL predict the risk for renal damage. This would mean for the daily practice that we have an earlier tailored intervention based on the risk stratification. As for the research, we need international trials to validate a risk score in this situation. Here you can see the search key we used at the beginning of November, and we obtained 7,000 articles at the beginning, from which we selected 103 eligible full text, and after the citation chaser step, we obtained another 33 eligible texts. Our outcome measure is the mean difference and the odds ratio with 95% confidence intervals, and we are still doing some analysis. Our outcomes are the biomarkers that we grouped in 3 domains: hematological and inflammatory biomarkers, immunological tests, and renal damage-related markers. I want to talk about our results a bit. The first one focuses on neutrophil to lymphocyte ratio. This is a very easily obtainable biomarker that is that means the ratio between the number of neutrophils and lymphocytes, highlighting the equilibrium between the active inflammation and the regulatory pathways that is focused on the lymphocytes. The normal range of this ratio is between 1 and 2. We analyzed 19 studies with more than 2,000 patients. All of them are observational studies, some of them are retrospective, some of them are prospective, and we have a high heterogeneity of 78% in this case, which can be explained by the variation of the neutrophil to lymphocyte ratio based on ethnicity. This might explain why at the top of the forest plot we have an article from Asia, and at the bottom of it there is an article analyzing Turkish population. Our pooled mean difference is of 0.5, which means that the neutrophil to lymphocyte ratio is higher with 0.5 in patients with renal involvement. This is a clinically and statistically significant result, and this means that it can help orientate the clinicians if the patients might develop renal involvement. Another biomarker we looked at is the platelets to lymphocyte ratio. Here the pathophysiology is similar. The platelets are increased during the inflammatory states, whereas the lymphocytes are decreased in these situations. We compared again the patients with IgA vasculitis with and without renal involvement. We have 12 studies with 2,000 patients. Here the heterogeneity is 49% and can be explained again by the variations based on ethnicity. And the pooled mean difference is of 8.76 in this situation, which would mean that the platelets to lymphocyte ratio is higher in patients with renal involvement with 8.76. This is not a clinically nor a statistically significant result because the difference is around 10% in the increase in platelets to lymphocyte ratio, but it shows a tendency towards this biomarker having a higher value in the renal involvement patients. We analyzed a lot of more outcomes, but for the sake of time, we needed to summarize them somehow in those three categories: renal damage-related markers, hematological and inflammatory biomarkers, and immunological tests. For some of them, we are still discussing with our team if we can consider them clinically significant or not. In summary, this is the progress of my first project. We finished the data extraction and we are now in the risk of bias assessment step, and also we are working on the figures and tables. Of course, we have some strengths and limitations. The strength is that we analyzed a high number of biomarkers. We have more than 30 biomarkers that we looked at. The articles have a wide geographical representation and we have a large number of patients included, more than 14,000 patients. But we are limited by the observational design of the studies and also by the lack of data about sensitivity, specificity, positive predictive value and negative predictive value. As I said at the beginning, we wanted to look at the predictive accuracy, and without these parameters, we are not able to do so. And also, we couldn't do a subgroup analysis based on the severity of renal involvement as we wanted at the beginning. A preliminary conclusion is that the neutrophil to lymphocyte ratio can aid in identifying patients at risk for renal involvement, and clinicians should take into account besides clinical risk factors that they are already looking at right now. Also, for the research, future studies should focus on the parameters that I mentioned before in order to analyze the predictive accuracy of these biomarkers. Also, a prediction model taking into account multiple biomarkers will be necessary. Going to the second project, it focuses on investigating the predictive accuracy of different histological classifications for renal outcomes in IgA vasculitis nephritis patients, and it will be again a systematic review and meta-analysis. About the background, as I already said, nephritis is the most severe manifestation of IgA vasculitis and responsible for long-term morbidity. In these patients, we need to look at the urinalysis for at least 1 year, and based on the modifications, the most recent guidelines recommend doing a kidney biopsy and classifying it accordingly to the International Study of Kidney Disease in Children classification. Where is the problem then? This 1977 classification focuses only on the active glomerular inflammation and neglects the vascular and tubular interstitial changes in these patients. But the most recent studies show that the proportion of sclerotic glomeruli and interstitial fibrosis, which are not active markers, are better predictors for long-term outcomes. We wanted to look at other classifications which seem more comprehensive and more promising in these situations. So our aim is to evaluate the predictive value of different histological classifications in establishing the severity of IgA vasculitis nephritis. The question we started from is, are newer classifications more accurate in predicting renal outcomes in pediatric IgA vasculitis nephritis? We used the PIRD framework to answer to that question, and we hypothesized that the Oxford and the modified semi-quantitative classifications predict the renal outcomes better than the International Study of Kidney Disease in Children classification. This would mean for the clinical practitioners that they have at hand a more comprehensive histological classification, which means a better therapeutic management in these patients. Of course, multicentric studies are needed to validate a new histopathological score. In summary, here are the 3 projects that I started this year. The last one focuses on investigating the prevalence of depressive symptoms in adolescents and young adults with chronic kidney disease, and it will be an Eurostat analysis, but for the sake of time, I didn't go into details about it. I want to finish all my projects by the end of this year. I'm very optimistic. And in the end, I want to leave you with a quote from Albert Einstein: "Once we accept our limits, we can go beyond them." Thank you for your kind attention.
You mentioned in the first project the high heterogeneity. Do you plan to do a subgroup analysis for this?
Yes, we are planning to do a subgroup analysis based on the region of origin of our patients. We don't have enough studies to do it country by country, but we identified some regions and we want to do a subgroup analysis in order to address that ethnicity related heterogeneity.
I would like to have a question about neutrophil lymphocyte ratio. Is it still feasible when a patient has any kind of infection?
Yes, there's a problem that all the infections can modify this ratio, and this is why in the articles we included, one of the exclusion criteria was the presence of a concomitant bacterial or viral infection.
What were the challenges when you did the data extraction?
Well, besides the large number of data that we had to deal with, and for this I want to thank Dori for helping me, one of the problems was the fact that these biomarkers are expressed using different unit of measure, and we had to convert all of them in order to be able to pool them. And we also had some situations where we weren't sure about the follow-up times or if the units of measures are correct because some parameters seemed wrong. So in these cases, we had to ask the authors about those informations, and in some cases we had an answer, in some cases we didn't, unfortunately.
I a little bit lost the line for the second project. So it's a classification for the outcome. And so it will be a retrospective data analysis, or how is your plan? Maybe you mentioned, but
yes, it will be also a systematic review. So we are not using our own patients, but as far as I saw in the preliminary research, the studies have a retrospective design. They took the biopsy samples and reclassified it according to the newer classifications in order to see if the newer classification is able to predict the renal outcomes better. And this helps us because the treatment is established based on the histopathological classification. And taking into account that they are not looking at the chronic signs, it might seem that the disease is not so severe based just only on the active inflammation, and they don't use very aggressive treatments. But in reality, it might be actually worse. Maybe there's a longer course of disease and there are more chronic lesions in those patients.